Hi, hello, good morning. Today we are going to discuss about cytopathology audit. So before goes to the session, please subscribe our channel, like our channel, and share our channels to your colleagues, your friends, and others. Thank you. So today we are going to discuss about cytopathology audits. So this also very important one. So before moving into the session, audits in the context of patient care, especially we call clinical audit, is defined as a quality improvement process that seeks to improve the patient's care and outcome through the systematic review of care against explicit criteria and the implementation of change. This aspect of the structure, process, and the outcome of the care are selected and systematically evaluated against the explicit criteria. They are indicated. The changes are implemented at an individual or team or the service level, and the future monitoring is used to confirm improvement in healthcare delivery. So the definition is endorsed by the National Institute for Clinical Excellence UK. The aim of the cytopathological audit is to achieve continuous improvement of all aspects of service and performance in a cytopathology department. So next we will move into the designing and implementation of a clinical audit. So under this, first we have to select. First one is the selection of audit topics. So this is through published guideline, research or comparison with the practice in other recognized laboratories and even compliance of the patient or the physicians, right? So by using this, we can select the audit topic. What is the topic we are going to auditing? And whether it is staining parts or whether it is sample preparation, auditing on the sample collection area or auditing on the uh, technical part or auditing on the reporting part or auditing on documentation, so we can decide. After reflecting on the purpose, the nature, and the style of the service that is required and how it is achieved by other labs, they should be compared with the current practice in the laboratory where the audit is take place. So we need to select this. Second one is the setting the standard. So identify the appropriate standard to compare current practice against. Right now we should know the standard. Then we can compare the current practice of the cytopathological laboratory and the standard we can compare. So where possible you should use published national, regional or local standards. So you can use a published one. Maybe this may be national or the regional or be maybe the local. If published standards do not exist, you may need to develop your own objective. Suppose if you don't have published standards, so you can develop your own standards by your experience, right? Objective and set a realistic standard to measure them against. To do this, you should use research evidence, past audits, and the consensus opinions. So these are the things you have to follow to set or prepare the standard for cytopathological uh, laboratory. So observing the practice. Next one is the observing the practice. So this is where actual implementation of the audit process begins. Data is collected to compare the current practice with the set standard. So now we are doing the auditing and we are collecting the data from the current practice, and by using that one we are comparing with already prepared published uh, standards. So this is then analyzed to come up with a result which will compare how close or not current practice follow the set standard. So by analyzing these the results data, by auditing result data and the standard, so we can compare our current practice whether we are following uh, published uh, standards or not. And next one is review. So there should be an open discussion of the audit finding and their significance among relevant professionals in the department with a identification of shortcoming. So by using our finding, audit finding, we can review it uh, and implement in future. Then the next one is consideration of options. So during the discussion, once shortcoming are identified, suppose if you are following, if you are not following some of the procedure with using a standard, so your procedures are deviated from your mm, standard procedure, so we call shortcoming. So if the audits identify this shortcoming, so the plan should be drawn up and agreed upon for correction of these. So if they identified, then they will plan how to improve. So and they will implement a corrective action, and they it's improve the service, so which are cost effective and practical and relevant. So it's actually cost effective, it takes time, right, and it's practical. And next one is changes, implementation of agreed changes in practice through education of relevant personnel and organizational mechanism. So suppose if we identify any gaps, right, so by auditing, so they will uh, suggest corrective actions. So suppose if they apply for uh, first corrective action will apply implement, and if it is okay, if it is corrected, okay, but otherwise they will find out that the gap or problem is due to what, personal error or the mechanical error, what is, then they will find out and they will give the training. Suppose if they observe this is due to personal error, they will give the continuous education or training or something, right? Then after that they will re-audit whether the finding errors or gap is resolved or not. Re-auditing, without a re-audit, it is impossible to judge if a action have been implemented, right? Re-auditing a topic after change have been made in an essential step in the audit cycle. Next one is the characteristic hmm, uh, of clinical audit in gynecological cytology. Internal quality control and the external quality assurance scheme must be in place, such as results of the pap smear must be classified according to the naturally recognized category. Next is correlation of pap smear results with where available colonoscopy or the biopsy results of the patient, analyzing and predictive values. Proficiency testing of all staff involved in reporting cervical cytology at regular intervals and comparison with national recommended standard if available. If seniors undergo preliminary screening by a cytoscreener or the trainee prior to begin reported by a pathologist, the sensitivity and the specificity of such preliminary primary screening should be assessed for individuals and for the laboratory as a whole. Then retrospective review of all smear with a diagnosis of CIN3 or HSIL or the cancer, and computerized access to all such quality assurance records. Then why should the gynecological cytology audit should be done? So a successful screening program should not only maintain standard that make it believable and acceptable to human, that means women, but also available. The audit should therefore ensure the acceptable turnaround time for reporting, use of proper terminology in reports, and proper intervals of screening, and the cost effectiveness of the screening program can be evaluated through the audit. And next one, the audit will contribute to training and the continuous professional development of all staff involved in the screening program. So that's why we need the auditing. Who should be involved in the gynecological uh, auditing? So everyone playing any role in the screening program should be involved in the auditing, from clerical staff to cytoscreener and the technical officer, district medical officer, nursing staff, other public health officers, especially those manning well women clinic in Sri Lanka, then gynecologist and the pathologist, family health bureau administrator, and official and the general practitioner. They all can involve in auditing. The clinician, including general practitioner, would be involved in auditing of turnaround time, screening interval, and the percentage of women recalled for repeat smear, and they would be also be involved in auditing of acceptable use of terminology in report to describe inadequate or abnormal smear. So here some people they can specify their auditing. So that's they are talking here. The gynecologist would be involved in evaluation of women with abnormal smear, referred for colposcopy and other outcome of treatment or follow-up. Then defining the scope of uh, gynecological cytology audits. First one is audit of screening program. If gynecological cytology is being used for a screening program, that means as an well woman clinic in Sri Lanka, so the screening program should also be audited, looking at the uptake and the coverage of women eligible for screening, the acceptability of the program to the target female population, the adequacy of smear taken, the consulting and the information given to women, and the effectiveness of the treatment or follow-up in avoiding development of invasive diseases or side effects. Although the cytology lab would be involved in such an audit to provide the data, this audit should be conducted primarily by screening program in their clinic. A person in charge should be the appointed for audit at each center, who should be involved in planning and the carrying out the audit, consult, coordinating analysis and the recording of results and making results available to those being audited. For example, we can say the smear taker. Next one is laboratory audits. The laboratory should conduct audits on technical and diagnostic aspects of gynecological cytology, as well as development and the evolution of any new techniques used in screening for uh, cervical cancer. So, implementation of clinical audit in gynecological cytology. So, it is include the following aspect. System should be in a place to audit at laboratory and or well uh, woman clinic level with a named person in charge. The numbers and the percentage of unsatisfactory sample. So the percentage of the abnormal results. Correlation with the histological results in abnormal cases. This would involve re-examining cytology and the relevant histology slides to assess the accuracy of original reports and their management recommendations. Accuracy of the smear takers should be audited and such results made available to them. If consistently below expected standard compared to the laboratory or the national level, discussion with the laboratory or the national coordinator of such audit should be ideally be mandatory and retraining be made available. Laboratories should report regularly on sample taker work. New sample takers should have feedback on their first 15 or agreed number of smear of the audit coordinator at laboratory or regional level. In the laboratory, auditing the performance of the laboratory as a whole and also a performance of individual screener and the pathologist, population coverage and the updates, multidisciplinary teams of the specialist nurses, trainees, etc., involved in gynecological cytology should examine all aspects of screening history of the cases discussed at the MDT meeting from in addition, recall or colposcopic assessment of fall safe action and the treatment. If the patient have been referred to any outside laboratories or colposcopy units for management, these can be contacted with their concern so that they may also participate in the review and contribute to the audit finding. Then mechanism of doing an audit. So first one is analyze the accuracy of abnormal gynecological cytology. That means sensitivity, specificity, false positive and negative rate, positive and negative predictive values. Second, the slide exchange scheme with the analysis of intra-observer verification in assessment. Right, next one, the multiple disciplinary specialist group include primary care and referral center should be used as a network for setting up and the implement gynecological audits. Next one, through the Family Health Bureau and or the College of Pathologists using a published national guideline for reporting cervical cancer as audit protocol or participating in any future multi-center uh, audit studies. So, next we will move into the clinical audits in non-gynecological cytopathology.